over to Dan.
Thank you. Yep, Daniel Bowman. I represent North Anchorage on the Anchorage Assembly.
Good morning, everybody. My name is Doug Schrocky. I'm the Anchorage Fire Chief.
Good morning, my name is Aisha Pallison. I'm with the Administrative Office of the Electric Court System. Good morning, my name is Hope Allison. I'm the Executive Director of Behavioral Health in Madison Regional.
Good morning. My name is Scott York. I'm the CEO of API.
Good morning, I'm Sarah Steele, the Providence Alaska Medical Center Chief Administrative Officer. Good morning, my name is Heidi Hedberg, Commissioner for the Department of Health.
Good morning, everyone. My name is Genevieve Mina, House Representative for 19 here in my district.
Hello, I'm Sarah Dwan, and I'm the Director of Integrated Behavioral Health at the Anchorage Neighborhood Health Center.
Good morning, my name is Robin Dempsey. I'm the CEO of Catholic Social Services.
Hello, good morning, everyone. My name is Nikki Tobin, and I am the...
Hello, everyone. I figured out how to operate the microphone. My name is Lucy Gail Tobin, and I'm the Senator for downtown Anchorage, including Jay Bear, Northeast Muldoon, East Ridge, parts of Fairview, South Nation, and North Star.
Good morning, my name is Jennifer Roxas, CEO of Alaska Regional. Good morning. I'm Michelle Brown from Rasmussen Foundation. Sorry for being lost. Good morning, I'm CJ Rook. I'm the clinical specialist RN through South Central Foundation's Behavioral Services Division.
Good morning, Kelda Barr, Staff Program Officer with the Alaska Medical Center.
Kimberly Brash, Acting Director, Anchorage Health Department.
Good morning, Mayor Dave Thomas.
Sanjao and Goyam. Good morning, my name is Kim Cole. I am the Commissioner for the Department of Family and Community Services.
Good morning, everyone. I'm Thea. I think I'm the convener for this task force.
Great, wonderful. And yes, and then John, as he already introduced himself, is the facilitator for the task force. So between John and Thea, they have really been doing a great job leading this effort. John, do we want to do just...
Yeah, quick.
Okay.
So have everyone else go around. So why don't we start here, we'll go this way, and then we can finish off.
So I'm Bill Dan, I'm part of John's team at PGS. Good morning, Chris Knights, also on PGS team.
Alexis Johnson, Anchorage Health Department, homeless coordinator for the meeting.
Good morning, I'm Anastasia Kenny. I'm one of the clinicians with the MIT team with the Anchorage Police Department.
Good morning, I'm Chelsea Ryan, and I work at South Central Foundation. I'm the nurse director for primary care.
Good morning, Darcy Nebula, Director of Operations for South Central Foundation.
Good morning, Bessie Odom, Virtual Chief of Staff for Senator Gary Jackson.
Great.
One of the TGA younger, community member, volunteer.
Hi, Dr. Chris Rucker. I'm the Chief Clinical Officer at Anchorage.
Just asking, Community Engagement Director for Mayor Bonner's office.
Michelle Little, Constituent Relations Director for Fairgrounds.
Veronica Hoxie, Communications Director for the Mayor's office.
Michael Hughes, Homelessness Planning Coordinator, Anchorage Health Department.
Good morning, Jennifer Bennett-Carson, Research and Policy for the Assembly.
Good morning, Genevieve Fukawa, Assembly Aide for Karen Brown.
Weston Early, over reporter with Alaska Public Media.
Tiffany Hall, Executive Director at Recover Alaska and Person in Long-Term Recovery from Co-occurring alcohol use and mental health disorders.
morning, Philip Tony, Executive Director of Alaska Mental Health Consumer Law.
Good morning, Dakota Orm, the Healthcare Integration Director with the Anchorage Coalition to End Homelessness.
Good morning, everyone. David Ridberg, Senior Director of Adult Homeless Services for Catholic Social Services.
Good morning, Dr. Angela Michaud, Senior Director of at CITC of Recovery and Reentry Services.
Dr. Shanti McDermott, dual board certified nurse practitioner of primary care, psychiatric, mental health, and I have too many jobs to list.
I'm Catherine McCoy. I'm an interested citizen, and I'm a volunteer at the Good Francis Shelter and sit on the Adult Homeless Advisory Council.
Jonathan Stonet, I'm the coordinator for the Anchorage Reentry Coalition.
Morning, DJ Tyson, Director of Communications for WALS.
And good morning, I'm Erica Steves. I'm the Director of Nursing for Alaska Psychiatric Institute.
I'm Laura Russell, Senior Behavioral Health Policy Advisor in the Commissioner's Office of the Department of Health.
Hi, good morning. Emily Ricci, Deputy Commissioner for the Department of Health.
Good morning, I'm Leah Costello. I'm with the Mayor's Office. Good morning, Amber Fraser, student with the AFD Full Courses team.
Mike Riley, thank you, Park Mobile Crisis Team.
Jennifer Pierce, lead clinician, Anchorage Fire Department, Global Crisis Team.
Claire Ross, I'm Legislative Services Director for the Anchorage Assembly. And people who RSVP'd, I made little nameplates for them, and if they didn't show up at this point, those of you in the back, feel free to come up to any of these yellow and green seats and have a seat. If you didn't catch my theme, the green seats are people who served on the task force that led up to this and our lists today.
Zach Hudson, Anchorage Assembly, District 6, South Anchorage, New Jersey.
Good morning, everybody. George Martinez, Anchorage Assembly, District 5, Eastern.
Hi, Anna Raleigh, also on the Assembly, District 3, West Anchorage.
Karen Rhonda, I'm having flashbacks of being the last person having to recite everything from those days. But I'm Laura Hanson, Anchorage. I've worked in behavioral health at API and Harvard Youth Developmental Center, fresh out of college. Been a 20-year teacher and now Anchorage Assembly, District 5. Thanks.
Great. So there are a couple of folks who haven't introduced themselves yet. Allie hasn't introduced herself.
Hi, everyone. I'm Allie Hartman. I'm the Communications Coordinator for the Anchorage Assembly.
Wonderful. And then Sylvia. Sylvia doesn't need an introduction, does she?
She's the president of the Downtown Community Council.
Great, thank you. All right, wonderful. So thanks so much, everyone, for coming today. A big thank you to my colleagues on the Anchorage Assembly for coming to this convening, to our state legislators and other statewide leaders for coming today. Appreciate the collaboration with the Anchorage Health Department and the mayor, so thank you, Mayor Bronson, and thank you, Acting Director Kim Rash, for being here today. My part for today's program is really to talk about how we got here, and then my hope for today, something that I think other folks will agree with them and get on board with. So really the inception for this task force and the conversation that we are having today really began earlier in the year in January. We knew earlier in the year that the emergency cold weather shelter was going to be closing at the end of April. And in January, several folks started ringing the alarm bells that we need to get ready for it. And eventually, there were folks, including myself, who predicted that we could really see mayhem, frankly, on our streets and in our green spaces, and we could see a behavioral health crisis spilling out to the entire community if we didn't get ready. So in March, the Anchorage Health Department presented the ideas for a demobilization plan. In April, the Assembly adopted a demobilization plan, taking some of the ideas that the Anchorage Health Department and the administration have put forward, ideas from some of our community partners, and ideas from community members. And the Assembly adopted that demobilization plan with multiple different planks in it. And one of those planks was the creation of a public task force to explore behavioral health solutions for individuals experiencing homelessness. Because again, going back to what I said earlier, we knew early on that that was going to be a huge issue that we needed to be prepared for and try to overcome. The task force started meeting in May, and John's going to go through all of that process. But we had a great amount of participation. We had, in some instances, upwards of 40, 50 people attending our task force meetings, from laypersons like myself and other community members who aren't behavioral health experts, but are invested in seeing solutions implemented, to professionals working in the front lines on this crisis. So I think we had a good mix of folks attending our task force meeting starting in May. We got a variety of viewpoints, and today, in my opinion, is the culmination of that work to get more viewpoints by bringing in what I call the big wigs. So the funders, the policymakers, the CEOs. For me, the goal today isn't necessarily that folks around the table write large checks, although I won't say no to that. The outcome that I'm looking for is that we align on 3 goals, and we're going to be talking about that soon, and that we're all committed to moving forward with action on these 3 goals that the task force has outlined. And again, I think action is the key word here. We've done a lot of studying about our behavioral health issues, but I think it's really important for us to take action today. I think we have an opportunity to really continue moving the needle forward. And I think we already had a big step this week, the groundbreaking of the Providence Crisis Stabilization Center. And I believe there's even more that we can accomplish if we collaborate, align, and leverage our resources, and working together, overcome some of the roadblocks to get progress forward on some of the issues that the task force has identified. So again, thank you so much for coming today, and I'm looking forward to a productive summit. I think I turn it back now over to John.
And in the interest of being on time in our schedule, which I think is my primary job as a facilitator, I'm going to be real brief about what our process was. But if anybody wants more detail about the process or really wants to dig into what happened at each meeting, we can provide that information to you. This is what the report you're seeing and where we're at today is the culmination of 5 meetings that were open to everyone to participate. Many people were invited. Over 100 people participated throughout the process, throughout the 5 meetings. Not always the same people. So we did have some people that came to every meeting, but one of the nice things was there were different perspectives in and out of each meeting. Each meeting built on each other. So the very first meeting, we brainstormed everything we could possibly think of that would fit this particular category. And then it got summarized into 3 focus areas. And then those 3 focus areas in the second meeting became the areas where we identified primary goals. And then through the subsequent meetings, we detailed out those goals and identified a number of actions and long-term goals and immediate actions that could occur there. And then from there, we identified what the primary goal should be to ask this group to help us accomplish. We then sent a survey out to everybody that participated in our process to ensure that they agreed that this was the primary goal and get all of their information and feedback, and we can give you the results of that survey as well when we do the final report. And what it came to is what you're going to hear now, the 3 primary goals that we want to address, and now it's to you. So we decided to go from the task force to bring it to you to say, how do we get to action on these goals? And then we'll pass it to me.
Great, okay. Hopefully you can hear me okay? Yeah, all right. It's awesome that you're all here, so thank you so much. And thanks so much to all the folks, many of whom are here today, that participated in all these meetings. So we're really at the culmination. We're going to be handing in our final report right before Labor Day weekend. So today is the day to really kind of distill what we want to move on and have that all presented to the Assembly coming up next week. So I wanted to just give a little bit of background, and some of this work is going to be familiar to some of you because we really try to build on other work that's already been happening in the municipality. So starting with our theory of change, and again, this goes back to work that happened during the pandemic. When we first started sheltering people in the Sullivan Arena, a number of healthcare organizations came together, many of whom are here today, to think about how can we actually deliver healthcare in the Sullivan Arena. And we met as a group over about 8 months to really develop
not only just the working agreements for how that was going to take place in Sullivan, and it did take place, and it was pretty remarkable, but also to think about what does this work look like post-pandemic? How do we actually get better integration between our healthcare services and people who are experiencing homelessness and seeking shelter, seeking supportive housing, seeking other types of supports. So we adapted the theory of change for this work from that theory of change that group of healthcare providers came together for a couple of years ago. So thinking about our long-term outcome, really our long-term outcome is that people who are experiencing homelessness or at risk of homelessness and also have complex behavioral health conditions, that they achieve whole person health and well-being. And I really think we all need to put our minds there. It's really not acceptable that we don't really strive to do that. It's really not acceptable that we I work downtown. I've worked downtown for the last 21 years. I grew up in this town. You know, I every day pretty much see somebody who's got significant physical and mental behavioral health issues, you know, experiencing very poor quality of life. So that long-term outcome is one that we've agreed on as a task force, and we would love it if we could all just kind of put our sights there. But that's a really long-term goal. So in terms of this project, what are our short and medium-term outcomes? There are really three. One is that people who are experiencing complex behavioral health conditions, are at risk of or experiencing homelessness, have access to integrated primary and behavioral health care. So that requires, as you're going to hear in our goals, engagement, probably kind of engagement first in more of an urgent care setting, and then helping that person move into a long-term health home where they can both get physical health care and behavioral health care needs met. And the wonderful thing is that here in our community, we have lots of providers starting to do that, trying to do that more. So we have places for that to happen, but creating that connection so people can really connect with that care is one of our priority outcomes. The second one is we really, you know, as we all do, want to see a decrease in unsheltered homelessness. So that really requires, as our community's been working on now for at least the last 5 years, really getting that pipeline from shelter to housing and then helping people retain housing, which, as we all know, often takes a lot of different kinds of supports for certain types of people. So we don't all just, you know, retain housing automatically. You know, many people need intensive supports in order to remain housed. So it's really that whole continuum from shelter to housing to retaining housing that's really important and an important outcome here. And the third one is that the way, we all know this, the way we deliver healthcare is the most expensive, fragmented, uncoordinated way. So we absolutely spend a lot of money on healthcare that isn't necessarily producing the outcomes that we want. So how can we really coordinate our care to drive towards, you know, supports that help people maintain their well-being, maintain their housing? So those are our three kind of big outcomes from this process. And then on the next slide, and you can read more about this in the report, there's a pretty detailed logic model in there. But I wanted to share this, which was used by permission from the Mental Health Trust. This is from a recent project that I worked on and also many of you are involved in, where we really tried to build out what does it look like to have a comprehensive system that helps people maintain their health and well-being in the lowest care setting, closest to home as possible, which by the way is in our Alaska statutes. That is described in our statutes as the goal of all of our healthcare services. So it's really this kind of connected web of behavioral health services, emergency services, basic needs, and then kind of connections and support. And that's a really important piece of this. You know, all of us kind of maintain our wellness because we are connected to other people and to our community. And that's a really important piece of this as well. And then as you go to the right-hand side, again, you can read this, you know, in the report in greater detail. But there are higher levels of care that are really necessary because people with complex behavioral health are going to periodically go into crisis. That's a normal part of having that disease. And so we have to have a system that when people escalate in their care needs, they then can also get returned back to that lowest level of care. So this is another way of thinking about what are the components that we need to have in place in our communities to ensure that comprehensive behavioral health continuum. And again, many people have contributed to that vision, and we can talk more about that. So let's just dive into our recommendations. As John said, we have 3 main goals, and then the task force, out of the menu of objectives we have under each goal, the task force has identified a priority objective for each goal. And that's what we're going to focus on today. We're not going to try and, what do people say, eat the elephant or whatever that is. We're going to really just focus on these 3 priority objectives, one for each of the goals. So our first goal is around system coordination, outreach, and triage. And essentially what we're trying to do with this goal is identify the most vulnerable individuals and address their care needs. So it's really about getting out into the community and finding the people who need this type and level of care and then engaging with them. So we know, and then our priority objective under this may actually feel to you like very bureaucratic. But in order to do that, as I think many of us know, it requires a lot of connection between systems that aren't well connected. And so our priority objective on this one is actually to identify and, if necessary, fund both a position and maybe a team at the health department perhaps, or it could be another municipal department that can really be the kind of backbone of this system for our community. So this is the place where we would convene, groups of interested providers. We could potentially, over time, kind of hold data there and see if we're making a difference. We could braid funding together. We could let contracts and then manage those contracts, much as the health department does already, but really to serve the development of the system. So that's really our priority objective under that first recommendation. And the next, there's a rationale for that for each of our priorities. So this is really just increasing participation, grading funding, allowing us to work together across our systems, because that's what's needed to help address the needs of people whose needs are in each of those systems. So, like, we're not talking about, oh, I just have like a problem with my leg and I can go and get physical therapy. We're talking about, I have complex issues and therefore I need to participate in many systems. And if those systems don't work together, I'm not going to get all those needs met. So we're talking about how do we bring all those systems together. Okay, so for our next goal, which you might look at this and be like, what? I thought you guys were the Complex Behavioral Health Task Force. Why are you talking about shelter and housing? But we know that being unsheltered is by itself traumatic. That if you are unsheltered for a period of time, you are at such higher risk for having so many other conditions that your condition deteriorates. So we do have our second goal as access to immediate, and we kind of went as far as to say no barrier. We had this debate, is it low barrier or is it no barrier? I know it doesn't sound super practical, but we went with no barrier because what we know, and I think we all saw this at the Sullivan, there's the people that end up in the warming shelter. There's the people that get trespassed. Even before COVID, we saw at Brother Francis and Dean's Cafe, there's the people who are on the sidewalk that APD is trying to work with all the time because their behaviors disallow them from being part of that congregate set. And that's really who we're talking about with this project, is the people who aren't fitting into our other kind of programs and systems. So what our task force came up with is that we really need a smaller scale shelter, very low tech. So this is hopefully also quite a bit more affordable. So what we're thinking of, and we drew some pictures of this that we'd be happy to share with you, is smaller spaces, maybe about 50 people max, a couple of sort of congregate, small-scale buildings. In my mind, I think of a portable classroom, something like that. And then some individual units, like those pallet shelters, because some people can't stay with other people. So we need to have some kind of individual spaces as well. Maybe there's porta potties, maybe there's a shower trailer. This is very low tech and it could be moved. But the important part for this population is that it's safe, it's secure, and it is year round. So it's not something that, like, we could repurpose it, we could move it if we didn't need it anymore, but we don't want people to enter into it and have to move immediately. Because for some people, it might take 6 months in that setting to be able to move into housing. And just like with any kind of shelter, the goal is always to move people into housing. But for some folks, that might mean visiting an assisted living, like there's been some great successes at API recently where they actually take the person to an assisted living home for 20 minutes and then take them back and go and train the people running the assisted living. This is what we need to do to help this person's behaviors. And it might take months for that person to successfully transition. So that's the type of support we're talking about being available through this kind of shelter. Okay, and for this last one, I'm going to invite Dr. Shantae McDermott to come up. Ooh, and Delphine's here too. Perfect timing. Come up, Delphine. Because this is the other companion piece of that shelter setting and for people experiencing unsheltered homelessness. So I'm going to invite Dr. Shantae McDermott and Delphine Atupeka to come up. And Shantae's going to talk about our third goal and objective.
So third goal and objective, very personal one for me, healthcare, care coordination, housing, rapidly assess and address housing, behavioral health, medical, and longer-term care needs. What me and Delphine have been doing, what I have been doing since I've been in Alaska for the last year, I started with choices that put me boots on the ground going into the Sullivan. It was myself and Dr. Van Ravensway and Shigoni, his physician assistant, that was providing on the ground care in that facility. From there, we were able to place them in housing like Rural Camp, Sitka Place, Carla, Guest House, and then from there, I was able to continue services by offering mental health and medical care to them, getting them stable so that they could be appropriate for an interview to get a job, so they could take over their own lease after their housing voucher ran out, to be able to go and be in the DPA office line for 2 hours and get their Medicaid benefits and their Quest benefits established. We had case management and peer support. When that program ended, then I transferred to Malvern to care, that's when I met Delphine, and we were doing the same thing. We have a relationship with API where their discharges come to me and I see them because they need long-acting injectables. They want to make sure that their patients don't fall into that great gap where they are lost waiting on a consult or waiting on a follow-up. They also can receive medical care because I also can do medical services as well as Delphine can do psychiatric. We have relationships with Anchorage where they bring their patients to us in the adult mental health rehabilitation program so that they can continue their care because some of their discharges are also from the Anchorage or for complex care. I have relationships with a lot of, I've kind of made this ragtag team that we can continue to do this kind of care, but essentially it's not sustainable because a lot of what we do as providers, it falls into case management. It's not reimbursable for our providers. So as of Friday, me and her were both let go from Mountain View Urgent Care because he cannot afford to keep 2 PAs and 2 MPs going out into the outreach with Anchorage Coalitions in Health. I covered the Davis pop-up, she covered the other 2, Cuddy and Third, and we were literally bringing those people in with the help of Mike Hill, who works for the ACEH. He would transport them to our clinic. We would do on-the-site psyche valves, medical care, get them started on meds, get their BODs done, which normally takes weeks to months because no providers are available, and they would get that process started to get those people placed. We've been working with Graceful Touch Transitional Services, the Alaska Samoan organization. We've made so many contacts, but this is still not sustainable. That's the reason why I have so many jobs, because it's paying, the other jobs are paying for the non-sustainable job, but this is my passion. This is where our drive is, and we're trying to help, but there's just not enough coordination of services. I'm in the case management meeting every Thursday from 1:30 to 2:30 with Match Properties and SCF Home for Good program. I'm with, we're out here networking, but there is a fragmentation where it is sometimes a barrier just to get the patient to that specialist that they need outside of primary care and psychiatric mental health services. On an average, my patient has 10 chronic comorbidities going on and double the medication routine. Sometimes no Medicaid. How do we get their meds? We're transporting patients to and from with the help of Arc of Anchorage when they bring their patients in, Rural Cap when they bring their patients, Graceful Touch when they bring their patients. But if they happen to be someone that we pull out of the camp who doesn't have those connections, now what? that's where the breakdown happens. That's where we are put in situations where, do we put them in the car? Do we call the mobile unit? Do we, like, what do we do? And so this one is very, very, very personal to me, because this is where I am affected and other providers are affected. I have doctors who want to go into the camps. I have people who want to keep doing this, but it's so hard to make it feasible. So we really want to look at that priority and objective, contract with behavioral health clinicians and peer providers to do the mobile outreach. There are providers out there that want to get out of the office, get out of that conclave of setting that they're in, whether it's hospital, and we want to go into those transitional housing. We want to go into the tents. I've done psychiatric evaluations in Davis Park in a tent. I was petrified of the scabies that I was possibly going to get, but that guy, today, right now, he's in housing and he's working. So it was worth it, what happened 6-7 months ago, and that fear of being cold in the snow, being in there where I don't know how, it's an unusual experience to do, but when you see the outcome of just what going a little bit beyond the boundaries of what normal medical care is, the outcome sometimes is so amazing. So we really want to be able to connect with the larger organizations and really get these people that continuity of care that they deserve so they can have the outcomes that we're looking for.
Thank you so much. That's really it in a nutshell, and I think just to put a fine point on that, while we've done so much great work with changing our Medicaid, the 1115, changing our Medicaid services, that works for folks that we can enroll in Medicaid. Some people don't qualify for Medicaid, others may not have ID, they may not even know their last name. And so when we can't get through that those very first hurdles, we can't bill for those services. And as you all know, still our Medicaid program is fee for service. So you have, and I do a lot of financial modeling for behavioral health, and if you can't meet certain volumes, you just can't keep your staff. So I just finished working with non-behavioral health services, and I can tell you that group has a passion for doing this work, but there right now isn't a financing mechanism to support it, even when the whole place is dying to do that work. So I think what we're talking about here is how do we create some local financing that would actually allow this very initial service to occur, where it's the outreach, the engagement, and again, that can take a while. That's I think both Delphine and Shantae and others can talk about that engagement can take a while. And so there has to be some way that we can support that work and so that we can then connect them with the services that are billable and that are supportable by the rest of our system. So Felix, that's our recommendations, and I think we have a little bit of time for discussions and questions before we go into our World Cafe. So I will adjourn. And next John.
Are there any questions for this session?
So, you mentioned POD or VOD, I'm not sure which, and I know what that was.
VOD, verification of disability.
Oh, VOD,
Yes.
okay, thanks.
We would love honest feedback and thoughts on these. So feel free to just jump in who would like to get us started.
Yeah, I have a question, and we can stay on the third goal just as an example. So you mentioned there's a disconnect between providers who want and are qualified and are ready to do these services, and then this kind of sustainable funding mechanisms to do that. So for this specific recommendation, are these things that, for example, could be Medicaid billable, and so it's a change at the state level, or are these things that are outside of that kind of bucket, and so they need another funding source, generally speaking?
Yeah, I think that's what we're speaking to, is that really for this type of outreach and engagement, it's really kind of pre-Medicaid enrollment, pre-Medicaid services. So yeah, we're talking about contracts that would provide for that level of outreach. That wouldn't, it's not that there wouldn't be any Medicaid billing, there could be, but it certainly won't be sufficient to pay for the program.
Yeah. And then a follow-up too, because I know there are some state grants, like behavioral health treatment kind of grant funding that's existed in the past. But is this kind of in that general bucket, and so it's a matter of directing those funding, or is this really kind of a new set of services that hasn't really been put into that system yet?
I mean, there are certainly services. I mean, South Central has an amazing intensive case management program. Providence is also a grantee and does an incredible amount of work. But those, I think it's fair to say, and I'd love to hear from providers too, that those services are maxed out, and when you're trying to address the needs of people with very complex and acute needs, it's kind of sometimes beyond what can be fit into those programs, because again, they're trying to make sure that they, have enough volume, have enough availability each day to keep their program sustainable. But I mean, I'd love to hear from, maybe if anyone from South Central wants to speak to that a little bit around your intensive case management, or other providers too that are trying to do that work, or Lauren too is here.
So our intensive case management program at South Central Foundation is absolutely maxed out right now, and we could quadruple that 3 times over and still be maxed out. And like you were talking about, the need is what happens before they get to that intensive case management state, and trying to get people into services, keep them into services, requires an inordinate amount of support system that Medicaid, Medicare, and no other insurance even remotely starts to cover. We have to identify the needs, and the amount of work that it takes to identify the needs is not covered by anything. And then for providers to go out into the community, right now the current model is you're getting paid for a 15-minute interaction. Well, going out into the community is an hour to 2 hours per patient customer. And that's, you multiply that by just the sheer numbers of folks that you see in the camps surrounding the city. It's a huge amount of funding that's needed.
Thank you so much. That's exactly true. We go out all day, 10 hours a day, seeing people, getting them established, getting their treatment plans, and then what happens when the medications need to be picked up from the pharmacy? Who do we call for that transportation gap if they don't have Medicaid or their Medicaid is pending and they cannot get a voucher and they don't have who come to the camps? So then that's where we are then sent to the pharmacy to pick up the meds that we prescribe, because what is the point of prescribing meds that are going to sit at Cars or Fred Meyer's or Walmart and no one picks them up? We know what's wrong with these people. They're telling us what's wrong with them. They're telling us they want naltrexone, they want Vivitrol, they want to stop using drugs, they want to be housed. But what happens when they see someone and then it's a broken system that they can't get back into that rigmarole, that continuity of care? And that's kind of where we're like the providers in the gray area. We're sending them to Anchorage Neighborhood Health, but it takes a couple weeks, sometimes a month or two to get in there to get an appointment. So in the meantime, we're those in between providers that are trying to keep them just in the system so they don't get lost again. And that is not billable. Some of our services are, but like she said, the majority of our time, those psych evals and some of these people, to do the eval takes 2 hours. To do the note takes 5. We're talking trauma, we're talking abuse, we're talking substance use, we're talking mental health, we're talking medical, we're talking everything being addressed, and we're getting it done. But what we're finding is that it's not sustainable. So we're bouncing around with different companies, because once they realize all the work we're doing, that they can't bill for all of it, they can't recoup all of that, it becomes unsustainable, and that's the problem. We can get them on Medicaid, and the great thing about Mountain View Urgent Care is that they will see regardless if you have Medicaid or not, and then they'll try to back bill Medicaid because that is an option. So that's why they have 211 coming in every Tuesday and every Monday for 5 hours to 8 hours to help the people in the clinic come in who don't have Medicaid. So we're trying to bridge that gap, but we can't do it without assistance from the other people that have the funding to help us do it.
Let me just ask, Lauren, do you want to speak to anything that you've seen kind of at the Bridge Clinic or Providence or any of that work?
I'm certainly, I echo much of what these providers have said, which is just that, yeah, and it's really tricky with the billable component to the case management and the key people to services. And I think we've had a lot of conversations about the gaps that exist, whether it's, walk-in space, which you guys so requiring that level of support. And as we make the transition to a crisis stabilization center, and we are hoping in the future to be able to shift what right now exists as a bridge clinic serving people with substance use disorders and providing medication-assisted treatment, which right now does not include intensive case management. We just don't have that capacity. It's not, a sustainable system. When we shift that into an urgent care walk-in model, we continue to be concerned about the same issue of how we're going to provide that. Well said.
Thank you. So I really appreciate all of that commentary. As a healthcare provider myself, and the way that I started doing optometry up in Alaska was going to remote communities and providing eye exams in school classrooms, bingo halls, and bowling alleys, you name it, anywhere we could stay warm and dry. So a provider's desire to go out into the community and provide that care, I think, is it's something that a lot of providers have interest in. You would have interest in doing it if it would be feasible for them to do so. And I guess, this sort of overlap between unmet behavioral health needs and homelessness. I know that Anchorage is not the only community in Alaska that is dealing with this, but I would argue that we are facing it most acutely right now. And we have several folks here from the state, there's Acting Commissioner Hedberg or some other folks who want to share. Are there opportunities that Anchorage is missing out on right now? I mean, how do we make more of this stuff happen where folks can actually go out into the field and provide that care and connect people with the services that they need? Is the state looking at that? Frankly, I'll just ask bluntly, how can Anchorage get more support from the state for making these type of things happen? Because we're treading water. Thanks.
Yeah, thanks. That was a large question. So first, I would say, I'm focusing on statewide. So there's workforce capacity and building up the workforce. And then there's looking at the systems and the payments systems. We do have a behavioral health roadmap, and we are going around the state, and there is one scheduled for South Central Alaska, and it's really, again, reconnecting with all of the providers on where they're experiencing gaps, and then we're identifying those gaps and how we can leverage system changes. And that sounds very lofty and 30,000-foot view, but I think we're seeing a recurring theme across the state. And so it's really great to hear from providers sort of where are those specific gaps in the continuum of care. Right now, we are exploring and evaluating various waivers from the Centers for Medicaid and Medicare, CMS, and it's around health-related social needs. So it's very much an exploration conversation as we're sort of evaluating the different waivers within CMS and evaluating what makes sense for Alaska. I don't know, I'm going to look behind my team and see if you want to ask me.
I can also speak very loudly. Emily Reedy, Deputy Commissioner of the Department of Health. And just to add to a couple of items that Commissioner Hedberg identified, I would add that we have, we have a kind of a new director in the Division of Behavioral Health who started in July, and part of what that does is gives us a little bit more stability, I think, to engage again in discussions with different provider groups, both in Anchorage and around the state, regarding, what is working with behavioral health services, whether it's grants or the 1115, what do we need to change? Not often, but sometimes I see some gaps between what is available from a programmatic and building perspective, and then what providers are aware of or what they are leveraging in terms of billing. And so to the degree that those exist, a short-term option, maybe to try to bridge some of those gaps, addressing the areas where there are inconsistencies, and make sure that we're all really leveraging the opportunities that exist within the current waiver. And then now is a good time for us to start talking about what within that waiver we may need to modify or change in the future so that we can start building that into our plan. So I think the financing can align really well with the needs that are being discussed right now. Some of that may already exist and we need to provide additional education and coordination. And then some of that we may need to build into our process and think about what that looks like a year, 2 or 3 years from now.
Thanks.
I have a question that I am not expecting to be able to be answered right now, but I'm curious if we have any idea what the number is, like how many dollars it will take to fill this gap, to supply these contracts, and if there is even a way to calculate a rough estimate of that. And then I'm also curious, we can't be the only state experiencing this who has this gap about care coordination prior to Medicaid services. And I'm just curious what other places have done.
I can take a stab at a couple of those. So just with the work that we've done related to behavioral health crisis and looking at different communities, so we do have some numbers to, kind of start from. We'll have a lot better numbers once we actually, have a crisis center operating. The mobile team has been keeping really good data, although they're not 24/7, so they're limited by their capacity, so we can't really just take the numbers of contacts they're having as that's who's there. But I think actually at a meeting a couple of weeks ago, where folks from API were there as well as other province and other folks, we had a little bit of an aha moment in the meeting where we were suddenly like, wow, we could actually start to really reduce the acuity kind of across our community by increasing access to care. And so I think what we're seeing right now is an incredible amount of untreated illness, and it actually probably isn't that many people. Like when we've done these projects before, the Pay for Success, which led to Home for Good, we did a whole pretty robust data analysis for that, and ended up with maybe around 700 people who really met all of the criteria for that project, which is a pretty complex set of needs. We do have some really great tools now with the Anchorage Coalition to End Homelessness. We've done a much better job at data capture over the last, I'd say, 3 or 4 years. And so in the report, you'll see a couple of kind of data markers that are within the data that the coalition keeps that would allow us to kind of get a decent count. But again, I don't think we're talking about thousands of people. I think we're actually more talking about hundreds of people, but whose symptoms and conditions are very severe. And so each one of them, like Delphine and Chante are saying, can absorb a lot of time. And that's what we're talking about too with intensive case management. So, but I guess I feel very hopeful that if we could start really focusing in on addressing those needs in a more robust way, that we then over not too long would see a reduction in acuity across the board. And I think that would be incredible for our community. And I know one thing that people get into is, wait, why are we focusing on this tiny group of really acute people when we should be doing prevention? I just want to explode that whole way of thinking, because treatment is prevention. Like when you have people who have very severe needs, they are experiencing trauma and they're probably also perpetuating trauma sometimes. And so when we actually try and address those needs, we're both preventing them from having to keep going in that circle, and we're also preventing other types of trauma that might happen. So really, we have to do both. And I know it's really hard to do both because there are very different ways of thinking and different programs. Again, the good news is here, we've actually done an incredible job with homelessness over the last 5 years. We've really addressed youth homelessness really head on. We've addressed family homelessness head on. We've made huge gains with veterans. And what we haven't done enough of is really thinking about single adults. And why does someone become a single adult? It's because they've lost all the connections, right? It's a product of a lot of trauma when you end up in that group. And that's what we haven't really focused on. So that's what we're talking about now. And it's hard. It's hard. So yeah.
All right, John, I gotta be bossy now, but This is a good warm-up because we're gonna get in and do work, all right? So we've got 3 different stations set up for each of the goals. I'm gonna randomly break you up into 3 groups. We're just gonna count off, like, and you'll go into your groups, and we're gonna go through a World Cafe model where you'll have about 15, 20 minutes at each group to be able to go through the process.
Sorry, last comment from Department of Health.
Yep.
Just go for it, right?
Oh, yeah, just real quick, I wanted to acknowledge, so Tiffany, your comment about care coordination. So when I say health-related social needs, as we're exploring and really having a statewide conversation, it includes care coordination. So there are waivers within CMS to pay for care coordination, so that's something that we're evaluating.
Before the people are on Medicaid.
Well, we need to be on Medicaid,
Okay.
right, but I think we're also,
Certainly part of it, but
Right.
it sounds like it's not.
Yeah.
That's great.
Okay, so, and we'll come back and have a chance to report out.
okay, real quick, I just wanted to acknowledge with the providers, we currently are right now, we have $5 million, and we're looking at the methodologies for Medicaid and rebasing. So we're taking a whole state approach, and I think that will address a lot of the providers, like the reoccurring theme of like being underfunded. So that's something we're currently doing right now.
So,
I'm sorry, can I cut you off for 1 second? Because she was reading my mind. And I want to change it from prevention for these members of our community to maybe change the word to transitions of where they are in their stages of life. And specifically, I have a current problem that's going on, and some of the commissioners in the room know what I'm dealing with, but transitions from custody. And so that's a population that we're missing, and they're becoming homeless, or they're sitting in our emergency room because there's no safe discharge for them to go back out in the street. So it's really about not prevention, let's change the word to transitions of their stages of whatever crisis that they're in, and how do we come up with those transitions in different settings.
So the reason why, one of the reasons why I'm pushing to jump in here is we want to capture all of this. And when we do the work, we're going to put these barriers and unaddressed things up there. But if they're set in this form, we're not capturing them, so we can't really. So let me break you into groups. We'll get you out there. So we're going to go, your first brainstorm everything you can think of that's happening within the category of the goal that you're at. Then from there, you'll also identify barriers. And then identify what you know is currently in place that maybe we need to take advantage of, and what is needed that we need to put in place. If during the discussion there's some quick fixes or low-hanging fruit that can just be done, there's a goal to capture that on. And then at the very end, we'd like to ask people to make commitments. What is it you're willing to do? What's the resource or action that you can give? And when and who will have it done? And you don't have to commit to lots of detail. You could say, I'll try to do this. We just want to get some actions up there. So we're going to go around. You'll have a chance to go to each goal in your group. So you'll rotate roughly every 15 to 20 minutes. And then once you've been to each of the goals, we'll do a lightning round where you can go back around one more time real quick and see if there's a commitment you want to add. So the first round, you really want to make sure you get the conversation, the brainstorm, identify the barriers, express what you know is currently in place, and identify what's needed. And then in the lightning round, you can come back through and say, well, I think I can take it this way. So I'm going to break you up. We'll count off 3. I'm going to start here 1.
1.
Yep.
2. 3.
You're 1.
One, one, one. 3.
1. 3. 2. 3. 1. 2. 1. 2.
All right.
3.
2. 3. 1. 2.
3.
1. 2. 3. Go.
1. 2. No? Okay. 1. Come back here. 2. Yeah, keep it going. Yeah.
3. 1. 3. 2. 1. 3.
3.
1. 2. 1.
3.
1.
2. Yep.
I'm just gonna.
Okay, so we got 1, 2, 3, right, so we got up here, group 3, goal 3 is here, so you'll start with goal 3. Goal 1 is over here, so you'll start with goal 1. Chris will be over here. And goal 2 is over there with Bill. You may need to move the tables a little bit to make some space.
I'm gonna slide by you real fast.
I'm gonna use the washroom all the time.
I gotta go.
But the brainstorm is really what matters. So again, for reference, this is the system coordination as far as outreach. Blue is how we define, and green is the primary priority objective. As we to identify and, if necessary, find a fund a position and team at the Anchorage Health Department or another municipal entity to manage contracts, leverage municipal, state, private resources, and coordinate municipal, state, and non-municipal entities in order to meet this. So, starting with brainstorm, I'm going to serve as your scribe for now, but if anybody wants further thoughts on paper, feel free to grab a marker and come on out. Otherwise, just any initial thoughts in reference to this goal? Throw them at me and yell.
We got about 10 more minutes in this round, so don't be shy.
And then everybody, they end up getting what they want to do. My heart is good in contract. Good people, and I'll tell you what's remember, one day you make me sick that you got the oil and the rock you come back. I can recognize that. Now you feel that. So that's how it's trying to I can recognize it. And he's like, good for that. I feel around you. And it's down to the it's all doing just to and I'm a black, so it's all hang out here. It's hard to get I'm gonna stick around when the end of it, okay? Right. Even know his name. Go on like that. Right before they get melted. Right. Well, if they enforce transportation, they can. They will keep what it is. And long at the end, that you can have. I mean, that's my opinion. They come, go come and make a show.
Now you don't want to participate, but you're welcome to like just hop in groups and listen to what they're saying.
So I'm just here to observe.
You can go observe right in there.
Yeah,
Hear the juice.
I'm just taking notes, but I appreciate it.
You got about 5 more minutes in this round, and then we're gonna rotate.
I was hoping the transition from custody. I don't know who that was.
Transition to custody.
They'll do that.
When someone's incarcerated, how they transition custody. I can look. Jennifer Oscar, O-S-P-U-T, with Thank you.
And then you're here. It's better that we run across each other. So wait, and I'm giving destiny. You don't care, I'll let you go. All right, you have to
brainstorm a barrier specific to that coordination piece when it comes to recovery. Names are like one of the hardest things. It's really
Not enough to
yeah, I know it.
All right, we're gonna get ready and start to rotate. So you're gonna rotate clockwise. So group 3 is gonna go over to goal 1. Goal 1 is gonna go over to goal 2. Goal 2 is gonna go over to goal 3. So you're rotating around the room clockwise. Pick up where the last group left off.
You guys are heading back to
Pretty random, yeah. I'm retired. Oh, I was on the task force, but honestly, I don't have any background. So I came at it thinking, somebody that was what I keep talking about, because it just seems like this issue that never gets taken out. And many people stop thinking about it. But that was the only thing that was driving me, but I learned so much. I mean, my first take on it was that everybody's a person. There's no way to think about it. But this is heartening to me when I was no. I just, no, I'm not, I would never go with politics.
second round.
I saw
Really talking about that. Feel free to review
there's the
that place brainstorm, and a lot of us carried over to
If anything happens to you, like,
the team members, the staff, and that's pretty fun day.
Yeah, when they're not corrupt, but I am very. Yeah, then he went to China. It's just like, yeah, I can do this. We were like, we were just so
I didn't know that John used to have that job. I worked for Zach.
Oh, that is funny.
Yes.
It is such a small world.
It is. It's one of my favorite things about it. Yeah.
Being complimented.
Yeah.
All right, you've got about 5 more minutes in this round. We're going to rotate. So about 5 more minutes. All last spots out.
Yeah, exactly. No. And you've seen this, you've seen this.
We have a good core people. So
thanks for everything.
So you and Jennifer here.
Yeah, we're both good. Yep.
Who are you?
Who's out there?
You got it. Therein lies some room for improvement. Yep. Thanks. Good to see you. Oh, absolutely. Yeah, it's important. It's not ideal being shut down, but it's worth being here. The larger cause, and hopefully it happens less and less. Working together.
Is it making sense to you?
Oh, certainly. I think I've been at it for 3 years. And so, and maybe eventually. How about that? Does that make sense?
So you're talking about system coordination,
Yeah, absolutely.
how that's defined, really the primary objective, identifying an individual or a team funding needs, service that we all need. We all pretty good to brainstorm, but they shot some very specific, in place, quick fixes and low end. Take language over,
She was extortionist. That was her goal, right? But I don't think right now, I think everybody's ready for some appetite for this. Oh, get your girl into yeah, well, I think that was called kicking the can. Okay, let them. Oh, yeah. I Yeah, that would be ready.
It would be ready. So I'm really proud that the department heads came up with what are aspects of and the answer is hotel conversion is a huge success. So there's still renovations, especially if you're taking hotels run down. So as I understand it, this winter and like the first through December, year, it's really about using hotels that exist in their capacity as hotels, right? So it's not even a whole conversion. It's looking for vacancies. So they put out a plus one. It sounds like they need some information from hotels that might give you capacity. Yeah. So it's less than like a whole conversion, more and more the answer, right? You're seeing so many hotels that don't pencil from a business perspective.
I do like, the more I think about
one of the things that I've really tracked with being is that if you're looking at like running a workshop, okay, you can have one operation that costs less. But yeah, you're missing the return on investment, right? And like the ability for that operator to staff if the staff are right? That's very
I know. No, that's okay. It's really nice to see you. I must have said and also, I think so cool. Yeah. Oh, I'm so sorry. I missed it.
No.
Actually, that was probably. Take care.
anything else, quick fix or mid to long-term commitment. Or you just want to they're on your mind. Or often in these types of things, Portland's in the Army for the it's not the neat prospect, but a lot of times there are these things already in place that we can capitalize on. So if there are any of those that have really good case, we do coordinate really well on this level and maybe achieve the scale. Those are good things to have.
Never know what to like write about.
Yeah, I wonder if this is like a stepping stone. Like I see that there's a story on the horizon. Like my hope is that something happens and that this can be a catalyst.
Well, things like
That's fascinating. A lot of times, the architect discharge unless they see the experienced person. And so, a lot of times it's like,
I mean, it's definitely the goal of this, right?
yeah.
All right, everybody, if I can get your attention real quick. Over here, group one, group two, the number two is the winner. They got done first. So they get the prize. But we're going to do just a quick, take a few more minutes to wrap up where we're at. And then if you want to rotate around by yourself at your own leisure and see if there are any commitments you can make or any actions you can add to this, that would be really helpful. We have a big picture now. We've done each of the projects, you've seen the notes, so at your own pace, not in the group, if you want to take a look at that, go through and see if there's anything you can add to the commitment list. And then also we'll have some lunch, we'll grab some lunch, and then after we'll have a closing discussion. So I'm going to let Felix encourage you to commit to stuff.
I also wonder.
Wonderful, thank you. Yeah, so thanks so much. This discussion has been really great. One of the things that I think is really important for us to take away is what our commitments as individuals, as organizations, what can we commit to doing? I think, like I said earlier, it'd be great if someone could write some checks at the end of this. But really, we're talking about some very concrete things, some of them policy-wise, some of them bureaucratic, and quite a few of them funding. So if you can make any commitments today to continue to engage in this, to be very actionable, I think that's what we really are looking for, these 3 specific goals. So I think we're going to finish up this group soon, and then after that, I just want to really encourage everyone to go through and look at the commitments that you can make as organizations and as individuals. Thanks.
Thank you.
I'm just lurking. Yeah. Oh, yeah, yeah.
Except I definitely said that. Like, I said, you know,
zone change, then I want that unit to be part of an inventory list stock. And if you want us to get part of it, I want sales tax dollars, I definitely want those units. Because that's what we do. That's one of the things that we we're counting on them to get to it. I don't want to come in and market people doing the homes. That's where I find that down. But we the city. And I ain't talking to you. I want us to get it on the road. I want us to get our problems on the table. Next 50 units of housing by next summer. That's what we're going to do. And then next year, all that living in, have to be our units that we can count on for 7 to 10 years. You can tax rates for a decade. We can count on that. You can't raise it, but you're going to count on it for a decade. We can have a whole impact. Sure, depending on right. You want to get involved with
Can I just introduce
like we do with
you? Hi, I'm Tia. And
That was what they were my, I'm here, and I get my people to be willing to me. And I did that, that night he told me, I do it. And said, get out of line, get what I'm coming out. I hate to my hands over here. Not so far, but she went to that. Don't be saying, wait, like your mom is, and you're not. I'm here for a reason. Because I care about my community, and I care about the less ones that ain't there. And to the worldwide didn't understand it. I kept a problem. Because I care about this. I can y'all what y'all understand. You don't got to do to you. You got to do to you. But they don't do that better.
Political dispositions.
You don't control Tony, how's it going?
everyone wants to start making their way back to a seat, we're going to reconvene and close so we can send everyone home. All right, thanks everybody. Well, welcome back. We're about half the strength, but we're here for all the good stuff. So we're going to go around real quick and have the people who are scribing for you share some of the quick fixes, low-hanging fruit, and commitments that came out of their goals. Then I'm going to pass it to Felix, who would like to give folks an opportunity for some closing comments, and then has some closing comments as well. And I do want to say, after you hear what came out of each group, I know it's hard to make a commitment on an empty stomach, but now you've had lunch. So if you decide you want to make a commitment on the way out the door, after you hear what commitments have been made, feel free to jump up and add additional tasks, things, actions you can take to the board. So I'm going to go ahead and start in the back with Bill.
All right, so our goal is around the shelter. And the quick fixes, they'll help us indicated that they have grant bill up to $1,000 that can be applied for. We had a story from Mountain View of submitting a number of grants last year, only to find out that the grants weren't purposed for what they needed, and so their thought is, let's, before we apply for grants, research that they are applicable to the solutions that we're striving for. We had a suggestion of using church volunteers and also high school and career center volunteers. The latter category, maybe giving college credits. And Jasmine, raise your hand, Jasmine, committed to contact the high schools to see if she could get that rolling. So we have to start with. We then had, I was shocked by this one, welcome a new nonprofit to open a shelter. Like we have to welcome them to do that, I thought. I would have thought anybody that had a shelter would be happy to do that without being asked. And then last one was to coordinate with the Alaska Army National Guard for engineers on construction. The commitments that were made, Catholic Social Services said we have policies, procedures, and operational documentation in place for how to operate a shelter. We'd be happy to share and do that now. And the same with a commitment from Catholic Social Services to assist with implementation of the 1115 waiver. The other commitment was Jasmine's. So we have lots of good ideas for how to move forward, and obviously lots of ideas about barriers. So
Thank you, Bill. Chris?
Sure. So we had goal 1, which was the system coordination for outreach and triage. So for quick fixes or low-hanging fruit, one was kind of already discussed, but finding other cities or locations that have had success with similar problems and sharing those good news stories in forums such as this to try and mirror or emulate some of those positives. Complex triage coordination efforts leverage at a higher level with shared end product. Coordinating with additional providers in coordination with the outreach pop-ups manager. And then the big one that was hit on often was a centralized list of all these resources for people to go to, whether that's a website, phone line, all the above. Couple of commitments down at the bottom. So one is continued involvement and resource sharing, covered Alaska. And then a recent ad was more coordination with street outreach, for example, providers in-person participation, pipeline to intake and assessment for the coalition of homes.
Thank you. And goal 3.
John, have you been just commitments or been quick fixes at the end of it?
You know, some of the folks didn't have many commitments, so I threw quick fixes in, but you really won the commitment goal here, so you can give them both, though. Give them both.
Give them both?
Yeah.
Yeah, okay. So quick fixes, low-hanging fruit, we have billing support and provider enrollment support to probably come from the state. Getting DOC involved, Department of Corrections, to include involving local stakeholders. Funding and reform for general relief support. It can be used for supplier, supportive housing, and not only assisted living. Better coordination of what services are available. When you get a bunch of people in a room like this, you hear, oh, I didn't know you did that, or I didn't know you did that. So better coordination. And
potential to use alcohol tax funds on providers and access to care. We had several commitments, one from Assemblymember Bolland, and I think the Assembly as a whole, and AFD, is to advocate for 24/7 mobile crisis team. From Representative Mina to advocate for general relief and behavioral health grants. Okay. Oh, and also from AFD, from the mobile crisis team, they provide education to master's and PhD level providers, training them on mental health training and experiences. Then we had Robin Dempsey from Catholic Social Services, who made a commitment to be a convener. She already has the Healthcare and Homelessness Partnership, which is a group that already currently meets, but she made a commitment to expand on that with the goal of coordinating efforts and keeping people knowing what each other are doing, so communication. And then last, we have Healthcare Liaison, so homelessness liaison at every hospital. And that was from Anchorage Coalition to End Homelessness. Thanks, everyone.
Thank you. So again, if you hear that there's anything you feel is missing, you want to go back up and add it, we're not done yet. So all of this data is going to be captured and entered into the report. The task force is meeting again tomorrow to process what came out of here and look at what came out. And then the final report will be published on the 5th. Right, the 5th? Through the Assembly? Yeah, great. So I thank you all for your time, and thank you for being here. I'm done being bossy, and I'm going to pass it to Felix, who has some general closing words, and then we'll let you get on with your life. Thank you so much.
Okay, great. Well, thanks so much, everyone, for coming today. I think before I give my remarks, I just want to give an opportunity to Commissioner Koval and the Deputy Commissioner to give some closing thoughts. And really want to appreciate so much state leadership being here for this conversation. It's really been helpful.
Thank you. So on behalf of the state and specifically the Department of Family and Community Services, we really appreciate that we have so many really dedicated and caring leaders here in the room, earnestly trying to find collaboration and answers. I don't like looking at the problem and just admiring it. I'm the go-getter that wants to solve it and move on. We have so many things to tackle. And just from a personal standpoint, as someone with lived experience, it's really heartening to see so many caring individuals trying to find a solution that fits different individuals and is unique. So thank you for your time and your effort. This is so well-meaning, and I know we're going to have some very productive solutions coming from this. Thank you.
I just want to echo Commissioner Koval's comments as well in terms of just really being struck by the amount and the dedication of individuals in this room. And I know this is kind of a microcosm of the work that's going on around the city and the state. When I look at the different, not boards, but I guess papers, and participate in these different discussions, I think what strikes me is the amount of work that is already ongoing, right? The amount of resources that do exist. And so I'm really excited to start with looking at how we can make sure that we are coordinating and effectively utilizing the different resources and the different efforts that are already ongoing at different levels. And I think being engaged in this conversation from the Department of Health side has really made it clear to me that we can do a better job of coordinating to make sure that the work that we're engaged in right now is also coordinated with the work of everyone in Anchorage here within the community. And so we're excited to begin to continue the conversation. This is really the beginning, but excited to participate and support in future events and be here as a resource. Thank you.
Great, thank you both so much. Yeah, we know that there's so much good that's happening in our community to address our behavioral health needs. I mean, just looking around the table here, there are so many leaders who have taken that mantle and who have run with it and who are doing great things in our community. I just want to everyone to just sit in that and know that so much great is happening. And I want to thank everyone for that. And I think we also know that there are gaps, right? And I've learned so much today about how the state is working to help overcome some of those gaps, like when it comes to waivers that I didn't really know before. And that so much more work needs to happen. I think this summit is really a continuation of a critical conversation to see how we can better coordinate our efforts, because we know that's critical, that we can't operate in silos, that we need to better leverage our resources, and that allows us to have more impact in our community. And I've heard that a lot today. We could really have more impact in our community if we're able to better coordinate and leverage. So I really appreciate the intent towards action today, and I feel like we've achieved that. I feel like I'm leaving this summit with some clear action and some clear commitment. So I want to thank everyone for doing that. And I just want to end that this isn't the end of the conversation. This is a continuation of the conversation towards action and towards solutions. And I look forward to continuing to partner with everyone here. Thanks so much, everyone.